Hello doctors, greetings from Dr. Bhatia Medical Coaching Institute, eGurukul Division. Let's take some questions which are very similar to the one that's been asked in INI-CET May 2022 exams. Now guys, as you are gearing up for your preparation towards NEET PG, these INI-CET 2022 model questions from physiology will be of very immense help to you, and that's going to add a good benefit to your preparation, guys. So without wasting much time, let me take up the very first question. Which clotting factor is reduced in pregnancy? Factor 12, 7, 9 and 11. Now with every question, I'm also going to give you the reference to the eGurukul physiology notes. It's my privilege and pride to say that more than 95% of questions has been taken from our notes, guys. So if you wish to read for your last minute preparation, this notes is going to be of immense help. So let's take up the very first question. The clotting factor that gets reduced in pregnancy, factor 12, 7, 9 and 11. Now guys, if you consider the clotting factors in pregnancy, always remember this. Pregnancy is more of a procoagulable state, alright? Now the importance here is, as I was just mentioning you, it's a procoagulable state. Almost all clotting factors level rises in pregnancy. Almost all clotting factor levels rises in pregnancy. So friends, this is more of a protective mechanism, alright? As the woman is about to lose more amount of blood during parturition, body in an attempt to prevent that excessive blood loss tries to increase the clotting factor level right from the early gestation so that the amount of blood loss during parturition becomes minimized due to the enhanced clotting factor level and augmented coagulation. So every single clotting factor level rises during pregnancy except, here it's the just people, every single clotting factor level rises during pregnancy except factor 12 and factor 13. The level of factor 12 and level of factor 13 drops during pregnancy. Very important point. Level of factor 12 and factor 13 drops during pregnancy. So every single clotting factors is significantly elevated except factor 12 as well as factor 13. What are the factors that rises to a very high degree? We could able to see a significant elevation in thrombin, fibrinogen, so the prothrombin level rises, which gets converted to thrombin, and there is going to be very high fibrinogen level as well as factor 7 levels, people. Factor 7, fibrinogen and prothrombin as well as thrombin level elevates to a very high degree in pregnancy. I repeat, factor 12 as well as factor 13 level falls during pregnancy. So guys, that's our very first question. So answer for the question, which clotting factor is reduced in pregnancy? Obviously, the right answer is factor 12. You just know factor 7 rises to a very high level. Factor 7 rises to a very high level. Factor 9 as well as factor 11 also rises. But comparatively, factor 7 elevation is much greater than factor 9 as well as factor 11b. Now, the reference is being given. You could able to refer this from our notes in the section blood and the subsection platelets as well as hemostasis. Let's take up the second question, doctors. Which among the following leads to detachment of myosin head from actin? It's a question on skeletal muscle physiology. So we have three choices. we couldn't able to get the fourth choice, people, so we are restricting ourselves to the three choices, right? If you guys could able to remember the choice that you have gone through in your examination, we request you guys to share it with us so that thousands and thousands of your juniors are going to get benefited. All right, so getting back to the question, which among the following leads to detachment of myosin head from actin? Release of adenosine diphosphate and phosphate, attachment of adenosine triphosphate on myosin head, attachment of adenosine triphosphate on actin. See guys, I think you are very familiar with the steps involved in actin myosin interaction as well as detachment. See, we have myosin forming the thick filament. Now, this myosin thick filament has got a tail, a neck and a head. So we have a tail region and we have a neck region as well as a head region, doctors. Now the head region has got a binding site for adenosine triphosphate. Head region has got a binding site for adenosine triphosphate. Now when a myosin head is attached to adenosine triphosphate, we'll put it this way, we have thin filament which is made of actin, troponin and tropomyosin. We have thin filament and let's take up a thick filament, doctors. Tail, neck as well as head. So when there is a full molecule of adenosine triphosphate attached to myosin head stays away from thin filament. With a complete molecule of adenosine triphosphate, myosin head is not going to get attached to thin filament. So there is no actin myosin interaction, there is no contraction of sarcomere, no contraction of myofibril, no contraction of muscle as well. So relaxed state is seen with attachment of adenosine triphosphate to myosin head. Now how does this myosin head gets for contraction? Whenever there is a breakdown of adenosine triphosphate, when adenosine triphosphate breaks down into adenosine diphosphate and a molecule of phosphate, we could able to see the tail, a neck and a head. Now this time we do have adenosine diphosphate plus phosphate. Now it's going to be attached with thin filament. The attachment of myosin head to thin filament is facilitated by breakdown of adenosine triphosphate. Now, if we could able to take the phosphate out, the head is going to flex. With complete detachment of phosphate, the head flexes. Now, this leads to a totally different orientation where the head is completely flexed, people. Head is completely flexed. So we have simple adenosine diphosphate alone and the thin filament is getting pulled off. And the thin filament is getting pulled towards M line. So to summarize everything, contraction, in another word, actin myosin interaction. Contraction or actin myosin interaction takes place with adenosine diphosphate attached to myosin head, while relaxation takes place with attachment of adenosine triphosphate to myosin head. Do you get this, doctors? So for effective relaxation of a muscle, you need adenosine triphosphate. I hope you could able to apply this knowledge in FM questions as well. After death, we are not going to synthesize adenosine triphosphate from the mitochondria. So without adenosine triphosphate, the myosin head is not going to get detached from thin filaments, actin, leading to post-mortem rigidity or cadaveric spasm. Alright people, so remember, I'm not talking about rigor mortis. That's a very different mechanism and whole separate events. This is just cadaveric spasm or postmortem rigidity due to lack of adenosine triphosphate synthesis from the mitochondria after death. Alright, so that is the second question. So answer for second question, people. Release of adenosine diphosphate and phosphate, absolutely no. This happens with contraction, right? When phosphate gets detached, you have significant contraction by flexion of myosin head. So that's not going to be our answer. Attachment of ATP on myosin head is the right answer for this question, number 2. Alright, so we have this question well covered and very much clearly explained in our notes. Again, you have the reference here, people. The page, exact page I am giving you. You have nerve muscle physiology section under which the topic has been discussed under the subheading neuromuscular junction excitation contraction coupling. So this screenshot is from our eGurukul physiology notes, doctors. Right? Let's take up the third question. Countercurrent mechanism is seen in eyes, kidney, testes, gut and lungs. Kind of a difficult question. Okay, let's start from the fundamentals and let's get to see how to approach this question first of all. Now, if you are very well read, fine, you're on the go and it's going to be a very simple question for you. On the other hand, if you are an average student, if you're not very nerdy and too much into the subjects or academics, and if you miss some essential physiological points, people, this question is kind of difficult for you. Anyway, let's try to address this. We have 4 choices. Now, the probability of narrowing it down to the right answer is now 0% as of now. But with a very basic understanding, we know that countercurrent mechanism is present in kidney. We all know that. GIT, yes, intestinal villi has got countercurrent mechanism. Testes do have countercurrent mechanism. These 3 structures do exhibit a beautiful countercurrent mechanism. So definitely option 2, 3 and 4 must be present in the answer. In all the 4 choices, option A has got 2, 3, 4, option B has got 2, 3, 4, option C do not have 2, so let us rule out option C, and option D also has got 2, 3, 4. Alright, so now the probability of getting to right answer is 25%. Alright, now we have efficiently ruled out 1 wrong choice. Now the competition is between three choices, A, B as well as D. So guys, let's see each structure one by one. When it comes to kidney, the countercurrent system you know very well. We have descending thin limb or thin descending limb that turns into loop of Henle, and loop of Henle ascends to form thin ascending limb, and we also have thick ascending limb. Alright. So what is the countercurrent system operating in kidney? Thick ascending limb is going to transport solutes out. Sodium, chloride. Predominantly sodium and chloride are thrown into the medullary interstitium through the transporter sodium potassium 2 chloride symporter, doctors. Alright. So the transporter is sodium potassium 2 chloride symporter, which is going to throw out solutes into the medullary interstitium. To compensate that, the ultrafiltrate that is flowing into the descending thin limb is going to lose water to the interstitium. Due to the significant medullary hyperosmolarity generated by solute transport from thick ascending limb, we could able to get movement of water out of descending thin limb. So one limb parallels the other limb. That's a countercurrent system, doctors. This is what is happening in kidney. Now, if you consider testis, now let us take up a testicular artery here. Testicular artery, people. Now testicular artery carries blood in it. Now blood comes with a temperature of 39 degrees Celsius. The blood that runs into the testicular artery comes with a temperature of 39 degrees Celsius. And it's very obvious and very basic that for effective spermatogenesis, the testicular temperature must be very less, and it must have to be lesser than intra-abdominal temperature. So when the testicular environment experiences high temperature, spermatogenesis is going to take a hit. So it's important that the temperature of the fluids that surround the testicular environment should be of a lesser temperature. Now how this is happening? Now as the blood is getting closer and closer to the testicles, testis as well as seminiferous tubules, people, right? Yeah, as the blood is getting very close to the testis and seminiferous tubule, the temperature is going to be lost. There is going to be loss of heat. Now which structure is going to receive the heat, people? We do have venous channels that is running very close to the arteries, and these veins are nothing but pampiniform plexus of veins. Pampiniform plexus of veins. The heat that is getting lost from the testicular arteries are going to be received by pampiniform plexus of veins, people. Just because the testicular arteries and pampiniform plexus are very closely located and the heat is lost from the artery to the veins, the venous blood is going to become high in temperature, and as the blood reaches, by the time blood reaches testis, blood will reach a temperature of 33 degrees Celsius, very suitable and comfortable for seminiferous tubules to promote spermatogenesis. So guys, as this blood turns back into the venous channels, the blood enters into the venous channels by a temperature of 33 degrees Celsius, and as the blood keeps moving into the pampiniform plexus, because it receives heat from the testicular artery, the blood that gets into the systemic veins from the pampiniform plexus is going to experience a temperature of 39 degrees Celsius. So between testicular artery and pampiniform plexus of veins, we do have transfer of heat. Unlike in kidney, where we have transfer of solutes and water, in testicular countercurrent structures, we experience transfer of heat, people. So kidneys as well as testis do express predominant countercurrent mechanism. When it comes to GAT, let us take up villi epithelium, guys. Let's take up villi epithelium. And let's take up enterocytes, intestinal villi enterocytes. Now, if you consider the villi vasculature, we have arterioles present in the villi, and very close to the arterioles we have venous channels as well. Now in GAT, what's going to happen is, people, as the blood flows into arterioles of intestinal villi, because of very close proximity, oxygen from arteries enters into veins. People. Now because of their proximity and very huge amount of oxygen transfer between arterioles and venules inside the intestinal villi, the terminal part of arteriolar blood, at this region is going to experience a very significant drop in partial pressure of oxygen. During normal conditions, this very little amount of oxygen that gets supplied to villi enterocytes is not going to cause any serious impairment in the functions of villi enterocytes. But in cases of challenges like mesenteric hypoperfusion, or when there is any occlusion of vasculature, or in cases of shock, these villi enterocytes undergo serious hypoxia, and this even might lead to mesenteric ischemia and damage, doctors. You get this? So in GIT, especially in intestinal villi, we do have arterioles as well as veins where no water transport, no solute transport, but here it's just pure transfer of oxygen from arterioles to the venule side, doctors, and this is how kidney, testis, GIT do involve in countercurrent mechanism. Now let us take up eye. Now this is one very important point, because this is something we have not very much often read or prepared for PG entrance exams. So this is quite a very new question, quite a very a rare question in another word to put up. So this might even determine your ranks or the seats. But thank God, at least we could able to understand and know this point at least now, so that when you take up NEET PG entrance exam, it's going to have a good impact, I believe so. So guys, let us take up eye structures. Now here, if you consider retina, we could able to differentiate retina into two different layers. We have outer retinal layer as well as inner retinal layer. Outer retinal layer as well as inner retinal layer, people. Now if you consider the vasculature, we have retinal artery or vessels that perfuses retina runs very close to optic nerve. Vasculature runs very close to optic nerve, people. So let me take up an optic nerve as well here. And if you consider the venous channels, the venous channels are arranged again very close to vascular channels, people. Now because of their proximity, we just discussed a similar kind of vasculature, arterioles and venules located very close to each other in intestinal villi as well, isn't it? In a very same manner, the vasculature, arterial vasculature shares oxygen out of it, and the venous blood is going to collect that oxygen. So we do have transfer of oxygen from arteriolar structures into venular structures, making outer retina to receive less amount of oxygen. So because good amount of oxygen is transferred to the venous channels, outer retina always will be in a state of less oxygen supply. To make matters worse, the inner segment of rods and cones, alright, the inner segment of rods and cones have got lots of mitochondria. So whatever the little amount of oxygen that goes to outer retina will be extracted by inner segment of rods and cones. So the maximum oxygen consumption seen in a retina is coming from inner segment of rods and cones, because they have tremendous amount of mitochondria, doctors. Alright. So outer retinal layers are practically vulnerable to hypoxic damages, and the reason is twofold. Number one, extraction of oxygen by inner segments of rods and cones. Number two, countercurrent mechanism for oxygen transfer happening between ocular vasculatures, arteriolar structures as well as venular structures, people. So guys, we have seen countercurrent system operating in kidneys, intestinal villi, testis as well as eye. So if you get back to the question, yeah, countercurrent mechanism is seen in. Now we know number 1, 2, 3 and 4 do have this countercurrent system. So where can we see 1, 2, 3 and 4 people? Option A. Option A has got 1, 2, 3 and 4. So that's obviously going to be the right answer, guys. So countercurrent mechanism is seen in option A, 1, 2, 3 and 4. Eyes, kidney, testis, gut. Now if you consider the last word lungs, please understand for fishes which has got gills involve countercurrent mechanisms. Gills involves countercurrent mechanisms, and this is for fishes, my friends. Please do not browse for the answers in internet and don't get distracted, because certain review articles do mention gills as respiratory system of fishes. So if you are in a hurry, if you don't pay enough attention, you might very easily get distracted. Please refrain yourself. Human lungs, human alveoli, pulmonary circulation, bronchial circulation or airways, no structures in human lungs is getting involved or getting manifested with a countercurrent system of transport, oxygen, carbon dioxide or temperature, nothing, doctors. So refrain from this answer. Human lungs do not have any system or mechanism that expresses a countercurrent flow. It is neither for oxygen, nor for heat, nor for any other gases, not for solutes, not for water. Alright. So please understand, fishes which has got gills may express countercurrent system of transfer of molecules, but never ever human lungs. So please refrain from this answer, and your answer is going to be, it is just eyes, kidney, testis as well as GAT. Especially when it comes to GAT, it is intestinal villi people. So that completes our third question. Alright. Now coming to the fourth question. Identify the correctly matched pair. Option A, simple diffusion, oxygen. Option B, facilitated diffusion, calcium into sarcoplasmic reticulum. Option C, primary active transport, glucose. Option D, ion channels, oxygen. It's a very simple question. It's been very many times repeatedly asked as well across the boards. We had questions on this topic in DNB exams, All India PG entrance exams, AIMS, JIPMER, PGI, Chandigarh. You take any board of exams, this question do find a place, doctors. Alright, it's very important. Transport across cell membranes or any membranes for that matter. Now the basics I hope you guys know very well. The transport can be divided into active transport as well as passive transport. Now when it comes to passive transport, we have simple diffusion as well as facilitated diffusion. Right. Now facilitated diffusion, you guys know it involves channels, very important, or a transporters, specific transporters. When it comes to simple diffusion, there is no need of transporters, channels or anything. It's just a movement of molecules across membranes. That is all. There is no need of any sophisticated transporting mechanisms. That's all. And when it comes to active transport, we have two subcategories. Primary active transport, which breaks a molecule of adenosine triphosphate by itself, and secondary active transport, which do not break a molecule of adenosine triphosphate, but it is dependent on primary active transport. Secondary active transport is dependent on primary active transport P. Alright. Now let us take up each and every step. When it comes to simple diffusion, simple diffusion is happening with gases. So oxygen, carbon dioxide, nitrogen and other anesthetic gases. Transport of these gases happens by simple diffusion, doctors. You know this. And the law that governs simple diffusion is Fick's law of diffusion. Alright. So that straight away takes us to the answer. Simple diffusion, oxygen is the correctly matched pair. Right answer is option A. What is wrong with option B? Facilitated diffusion. Calcium into sarcoplasmic reticulum. Calcium, if it is moved by calcium channels, if movement of calcium happens by calcium channels like voltage gated calcium channels, yes, now you can call this as facilitated diffusion. From a high concentration to low concentration, calcium is transported through a channel and we call this, right? We call this as facilitated diffusion. On the contrary, if calcium is transported along with sodium in the form of sodium calcium exchanger, sodium calcium exchanger is an example of secondary active transport which is getting operated on the plasma membrane of cardiac myocytes. You guys know very well, cardiac myocytes do not have greater number of sarcoplasmic reticulum, which is why they don't have a high efficiency of calcium storage. So in order to compensate that, a cardiac myocyte is dependent on extracellular fluid calcium for its contraction. When that same cell goes for relaxation, the calcium needs to be pumped back into extracellular fluid, which is done by sodium calcium exchanger, which is an example of secondary active transport. The third transporter for calcium entry. Let's take up the third transporter, that's Rhinodine Receptor. RYR standing for Rhinodine Receptor, which is present in sarcoplasmic reticulum. Skeletal muscle cells or cardiac muscle cells, whatever the sarcoplasmic reticulum that's available within the cytoplasm of skeletal as well as cardiac myocytes. We have Rhinodine receptor on the membrane of sarcoplasmic reticulum through which calcium is extruded out. Again, Rhinodine receptor is an example of facilitated diffusion because calcium moves from high concentration to a low concentration region. Sarcoplasmic reticulum has got high concentration, cytoplasm has got low concentration. On the other hand, you take up the same sarcoplasmic reticulum but in another transporter called Serca pump. Sarcoplasmic endoplasmic reticulum calcium ATPase, which is going to pump calcium into the sarcoplasmic reticulum. Rhinodine receptor takes calcium out. Very important, people. Calcium comes out. Comes out of sarcoplasmic reticulum. While Serca pump is going to pump calcium in. It's going to pump calcium into the sarcoplasmic reticulum. Alright. So, Serca pump is an example of primary active transport. Serca pump is an example of primary active transport, doctors. Alright. So, we have seen the ways with which calcium is getting transported. Now, if you take up the third choice, glucose, how glucose is getting transported? When it comes to glucose transport, friends, glucose is predominantly transported by two ways. Number one, let us take up a cell and let's differentiate the cell into two membranes, apical membrane as well as basal membrane facing the interstitium. Through apical membrane, entry of glucose through apical membrane, be it GIT epithelium or renal epithelium, the entry of glucose into the cells is always coupled with sodium. Every time the entry of glucose is always coupled with sodium, and this transporter is sodium dependent glucose transporter, which belongs to sodium dependent glucose transporter belongs to secondary active transport mechanism. And efflux of glucose out of the cell via basal membrane, the way with which glucose is taken out of the cell across the basal membrane, this transporter is called as GLUT2 transporters, and this belongs to facilitated diffusion. Facilitated diffusion, guys. So entry of glucose is by secondary active transport, while reabsorption of glucose across basal membrane is by facilitated diffusion, doctors. But never ever it's going to be an active transport. So primary active transport for glucose is wrong. Option B, facilitated diffusion, calcium into sarcoplasmic reticulum, wrong. Calcium out of sarcoplasmic reticulum, yes, facilitated diffusion through Rhinodine receptor. But into the sarcoplasmic reticulum happens by calcium ATPase, SERCA pump, that's a primary active transporter. And then ion channels, oxygen, not at all possible. Oxygen is transported by simple diffusion, you guys know that very well. While ion channels are involved in facilitated diffusion, guys. So let's complete the answer with the last point, ion channels. Ion channels undergo facilitated diffusion. And it's not going to take part in oxygen transport, guys. So answer for the question is option A, simple diffusion, oxygen. All right. Again, we have the same topic beautifully described in our notes. The topic name is general and cell physiology, and the subtopic name is transport across cell membrane, guys. I've given you the screenshot as well. So if you would like to have these notes, contact us. We'll be sending you this, and you can have a thorough reading from this. Coming to question number 4. Which of the following is not a cause of central cyanosis? Option A, methemoglobinemia. Option B, pulmonary arteriovenous connections. They mean fistula here, hypothermia and high altitude. Alright, now you need to know what is central cyanosis first to get this question straight. Right, now in central cyanosis, the pathology is seen with defective oxygenation of blood. Defective oxygenation of venous blood. So when venous blood coming from right ventricle cannot able to get completely oxygenated, or when blood from the right ventricle is not even reaching a lung. So ultimately speaking, when oxygen is not reaching a blood, it can be a problem of oxygenation, it can be a problem of blood flow, it doesn't matter. Now when the whole sequence of oxygenation has to happen well, and if there is any interruption, blood is not going to receive oxygen, leading to central cyanosis. The whole body is going to turn blue because of the melanin pigmentation of skin in Indian continent. We restrict the visualization of central cyanosis to mucous membranes of lip, tongue, buccal mucosa, if at all to earlobes, tip of noses and all, because these are the regions that are very stretched and very easy to identify the bluish discoloration. All right, people. So for solving this question, you need to know the whole sequence with which oxygen reaches a blood. Now let us start the whole sequence from atmosphere. Oxygen from atmosphere gets into the lungs. So let us take up an single alveoli representing an entire lung, people. And to receive the oxygen, we have pulmonary capillary, which is going to get blood from right ventricle. So we do have deoxygenated blood flowing into pulmonary capillary. Deoxygenated blood flowing into pulmonary capillary, and there is going to be transfer of oxygen from alveolus to pulmonary capillary. Thereby, as the blood gets out to left atrium, the blood is going to be a oxygenated one. Oxygenated blood. This is the whole sequence, doctors. I hope you get this. So oxygen from atmosphere gets into the lungs, oxygen from the lungs gets into pulmonary capillary. Now ultimately speaking, for the blood that needs to get oxygenated has to come from right ventricle. Alright, if there is any problem in this process, and when oxygen enters into pulmonary capillary, guys, there is another mechanism you need to understand here. Inside the pulmonary capillary, we do have red blood cells, RBCs, which consist of hemoglobin. So the oxygen that enters into pulmonary capillary is going to take up two forms. The first form is oxyhemoglobin, where oxygen combines with hemoglobin and gets stuffed within the RBC, and the second one is dissolved form. So the first form is oxyhemoglobin form, and the second form is dissolved form of oxygen in plasma. And you guys know very well, oxyhemoglobin form carries 97%, dissolved form carries just 3% of total arterial oxygen, isn't it? So for a blood to be effectively oxygenated, you need good amount of oxygen in the atmosphere, you need entry of oxygen into the lungs, you need transfer or diffusion of oxygen across the alveolar membrane into the pulmonary capillary, you need the oxygen to get combined with hemoglobin to stay as oxyhemoglobin, and that's the majority of oxygen transporting mechanism, isn't it? Now all the process must happen for effective oxygenation. Now if everything happens well, you also need to ensure that adequate amount of blood is getting ejected out of right ventricle into the pulmonary circulation, so that the oxygen is going to be extracted by the blood of pulmonary capillaries. So you need good oxygenation, you need good blood flow. All the sequence has to met very perfectly for oxygenation to take place, and cyanosis is not going to happen. If there is any interference in these mechanisms, we expect defective oxygenation of blood leading to cyanosis, doctors. Now the table is going to give you all the conditions that's going to cause central cyanosis as well as peripheral cyanosis. Alright, now the table is for your description and it's for your better understanding. If you want these points, pause the video, take a screenshot and be thorough with all the conditions. Let's get through the differential diagnosis and let's find a way to answer this question. Methemoglobinemia. What is methemoglobinemia, doctors? So if a hemoglobin is normal and if a hemoglobin needs to combine with oxygen, the hemoglobin must be having iron in ferrous form, so that this ferrous form of iron is going to combine with oxygen. In case of methemoglobinemia, the iron is going to be present in ferric form. Iron in ferric form is not going to combine with oxygen. So when blood methemoglobin concentration significantly rises, we call the condition as methemoglobinemia, and this ferric ion containing hemoglobin is not going to combine oxygen, leading to defective oxygenation of blood, causing central cyanosis. So methemoglobinemia will cause central cyanosis for sure, no matter what. Number 2, pulmonary arteriovenous connection. Now you guys know the blood from right ventricle is carried to lungs through pulmonary artery, and the oxygenated blood from the lungs gets into left atrium by pulmonary vein. So pulmonary vein carries purely oxygenated blood, pulmonary arteries carries deoxygenated blood. When there happens to be a connection, arteriovenous fistula between pulmonary artery and pulmonary vein, there is going to be mixture of pulmonary arterial blood into pulmonary venous circulation, leading to arteriovenous communication of blood. This reduces oxygen content in the pulmonary venous circulation. All right, the deoxygenated blood present in pulmonary artery is going to contaminate the oxygenated blood present in pulmonary vein, and this leads to defective oxygenation of blood, and this will lead to central cyanosis. So pulmonary arteriovenous fistula, pulmonary arteriovenous connection will definitely bring about central cyanosis. So that again, that's not a right answer. Moving on to option C, hypothermia. Usually with severe hypothermia, again there is going to be a defective transport of blood, people, but not to the point of complete central cyanosis. Usually with hypothermia, the peripheral vasculature goes for contraction early. So when the peripheral vasculature gets constricted early, perfusion to peripheral tissues and distal tissues gets compromised. So even before a central cyanosis manifests, patients will develop peripheral cyanosis first. And no hypothermia is so brutal to cause a central cyanosis, people. Alright, so comparatively speaking, hypothermia is not a very favorable condition to cause central cyanosis. High altitude, you know very well, as we keep moving up in the altitude, the atmospheric oxygen level decreases. So when the atmospheric oxygen itself is reduced, there is going to be poor oxygenation of lung. This leads to poor oxygenation of capillaries, pulmonary capillaries, poor oxygenation of blood, causing central cyanosis. Alright, so methemoglobinemia, pulmonary AV fistulas, high altitude or straight causes for central cyanosis except hypothermia, and that's the right answer for this question, which is not a cause of central cyanosis. The right answer is hypothermia, doctors. Now you have the table here that lists every single condition that's going to cause central cyanosis as well as peripheral cyanosis, doctors. And we had this in our notes as well in the topic respiratory physiology, where carbon dioxide and oxygen transport has been discussed. Okay, so for your better understanding, you can refer to our notes as well, guys. Let's take up question number 5. Match the following transporters with the molecule they carry: hemopexin, haptoglobin, prealbumin, albumin. And the molecules are heme, hemoglobin, thyroxine, free fatty acid. It's a very straightforward question, no concepts, no logic, nothing. It's more of a mugging up topic. You need to be familiar with plasma proteins which are involved in carrying certain molecules. That's all, guys. Right? Now, hemopexin. Hemopexin is a protein that is involved in transporting free heme to liver. Very important. When hemoglobin gets released out of RBC, the hemoglobin is broken down into heme and globin. The heme part alone is carried by the protein hemopexin to liver. So remember, after the breakdown of hemoglobin, the free heme alone is carried to liver by the protein hemopexin. When it comes to haptoglobin, the hemoglobin combined molecule is carried to reticuloendothelial system by haptoglobins. Please understand, hemopexin carries free heme to liver, while haptoglobin carries the entire hemoglobin molecule to reticuloendothelial system like spleen and lymphocytes, lymph nodes. Okay, so haptoglobin carries hemoglobin, globin for globin, people, remember that way. Haptoglobin carries hemoglobin, while hemopexin carries free heme. All right, second protein. Third protein, prealbumin, very important, and you must be knowing this. Thyroid hormones T3, T4 are bounded by two kinds of proteins. Number 1, thyroid binding prealbumin. Thyroid binding prealbumin is also called as transthyretin. The newer terminology is transthyretin. Number 2, thyroid binding globulins. Alright people, so you have thyroid binding prealbumin, also called as transthyretin, and number 2 thyroid binding globulins. Alright, number 4, this is quite new and you must not have crossed across this point very frequently. Amino acids at times carry anionic charges. At times carry anionic charges. These anionic charge carrying amino acids are frequently seen in combination with albumin. Alright people, so these are the corresponding proteins which carry the respective molecules. So in this question it's been given in the right order. Hemopexin is going to carry heme, while haptoglobin is going to carry hemoglobin. Prealbumin, thyroxine. Albumin is going to carry free fatty acid people. So these are the transporters that is going to carry the respective molecules. And again, as I told you, we had this covered in our notes itself, and the page number itself is given people. In the topic blood, in the subtopic plasma proteins, we have it completely covered. This is for your reference. So get this clear in your mind, okay? Sixth question, beautiful question guys, very interesting question. What will happen to alveolar ventilation when pH is changed from 7.4 to 7.3 at a partial pressure of arterial oxygen 100 millimeters of mercury? Now this patient is going to have a development of acidosis. All right, the pH is going to fall from a normal pH of 7.4, it has fallen to 7.3, an acidic pH. But the partial pressure of arterial oxygen is absolutely normal. It's even higher, right? 100 millimeters of mercury. In the picture, you have series of curves given, out of which we have a normal curve, and we have series of curves that is represented by A, B, C and D, and we are supposed to identify which curve fits for the condition where the patient is developing metabolic or respiratory acidosis, whatever it is. Now, as per the graph or with any graphical kind of questions, the first and foremost thing you need to do is not to panic. All right, do not worry, doctors. You will not be asked any complicated graph to solve. You just need to hold your nerves. You just need to stay calm. Do not worry. Please trust us. It is definite that the graphs that you are going to get in your questions may look complicated, but they are very simple, and it will be designed in such a way that you could able to find the answer within that stipulated time period. All right, so don't panic, just get to the basics and look at the axes first. In x-axis you are getting partial pressure of carbon dioxide, arterial carbon dioxide, partial pressure of arterial carbon dioxide. On the y-axis you have minute ventilation. On the y-axis you have minute ventilation, people. So we have partial pressure of arterial carbon dioxide on x-axis, and on the y-axis we have minute volume, minute ventilation. Now the normal curve states normal partial pressure of arterial carbon dioxide, that's about 40 millimeters of mercury. All right, normal arterial PaCO2 is 40 millimeters of mercury. What is going to happen with acidosis? You guys know very well, when there is going to be an acidosis, if the respiratory system is going to be normal and the metabolic dysregulation is the cause of acidosis, the patient is going to experience reduction in pH. This reduction in pH is sensed by pH of arterial blood. The reduction in pH is sensed by peripheral chemoreceptors, very important. Central chemoreceptor senses fall in pH. All right, central chemoreceptor senses fall in pH of cerebrospinal fluid, not arterial blood. while peripheral chemoreceptors, which are located in carotid body and aortic arch, are going to sense a fall in pH of arterial blood people. That's very essential. When peripheral chemoreceptor senses the fall in arterial pH, it's going to activate respiratory centers. And this is going to cause hyperventilation. Now this will happen only when the respiratory system is normal and it is a metabolic acidosis. If it is a respiratory acidosis, the whole problem is because of inefficient ventilation, isn't it? So, because we have a normal PaCO2 curve, this might indicate a metabolic problem and not a respiratory problem, people. So obviously, because of metabolic acidosis, the whole sequence is happening. There is a fall in arterial blood pH sensed by peripheral chemoreceptors leading to hyperventilation. And you, my friends, know very well what happens with hyperventilation. With hyperventilation, there is going to be a carbon dioxide washout. When carbon dioxide washout takes place, there is going to be a fall in partial pressure of arterial carbon dioxide. Now, in the curve that you are seeing, every single line, line B, line C, line D, everything indicates increase in partial pressure of arterial carbon dioxide. Except for line A, that indicates a fall in partial pressure of arterial carbon dioxide from the normal value. Only line A indicates a fall in partial pressure of arterial carbon dioxide from the normal value. So what will happen to alveolar ventilation when pH is changed from 7.4 to 7.3? Obviously, the right answer for this question is line A, people. Right answer for this question is line A. It's a very, very, very important graph. As we just touched this graph and landed up with the right answer, let's also get to see the other values associated with the graph given in the textbooks. Alright, so we just discussed metabolic acidosis where we have seen line A. Now if you take up other three lines, people, B, C and D, everywhere you could able to see respiration is getting compromised. During sleep, during opiates, as a drug in the poisonous state, in severe anesthetic conditions, in all the three conditions. In all the three conditions, B, C as well as D, in all the three conditions, there is going to be a fall in respiratory drive. There is going to be a fall in respiratory drive leading to hypoventilation. Because of hypoventilation, there is going to be an increase in partial pressure of arterial carbon dioxide level. So friends, if you get across a similar question, maybe in NEET PG 2022, maybe in the next year question papers as well, never ever you should forget, when the lines are seen on the right side of normal value, it means partial pressure of arterial carbon dioxide is increasing, there is a respiratory depression. When there is a curve to the left of normal curve, partial pressure of arterial carbon dioxide, it means there is a hyperventilation where the lungs are working fine and it is getting activated by other processes like metabolic acidosis. Alright, so this graph is quite interesting and important, people. I hope you get the whole idea here. Again guys, we have the same topic discussed well and good in our notes, respiratory physiology topic. In the subtopic chemical control by chemoreceptors, I have shared these screenshots with you for your references and for even better clarity. Moving on to the next question. Identify curve A and curve B. Now again a graphical question. As I told you, do not panic, look at the axes first. Now I think you could able to narrow down your thoughts to this one point itself, minus 70 millivolt. What does this rings you? Minus 70 millivolt, the value tells us this is the resting membrane potential of a neuron. Plus 40 millivolt, again this is an action potential value of a neuron or any cell for that matter. Vm stands for membrane potential. membrane potential. And this question is about the ionic conductance. This question is about the ionic conductance causing the depolarization and repolarization in a neuron. So, the moment a neuron reaches threshold potential, the first ion to enter into a neuron to go for depolarization is sodium ion, happening through voltage gated sodium channel. So even before the second ion gets in, there is going to be a tremendous influx of sodium into the cell. So A ion indicates entry of sodium or sodium conductance. A ion indicates sodium conductance. With tremendous influx of sodium, you guys know the consequence. There is going to be huge amount of water inflow. In order to compensate the cellular volume expansion, the neuron is going to pump, or it is going to throw out potassium out of the cell. As the neuron throws potassium out of the cell by leaky potassium channel, the potential also comes down, the cell volume also going to come back to normal limits. So as a consequence of sodium conductance and increased intraneuronal volume, potassium ion starts to come out. So curve B represents potassium conductance. Curve B represents potassium conductance, people. So A and B, A stands for sodium conduction, B for potassium conduction. That is shown in option A, and that is the right answer for this question. Option A, calcium, B, sodium. Absolutely not. Right from the first go onwards, you have to rule out B and C option, because repolarization is never ever caused by sodium ion. And option D, depolarization by calcium, repolarization is by potassium. Which cell can behave this way? Of course, it's not the right answer for this question. What cell can display such a kind of pattern? Depolarization by calcium ion is seen in number 1, smooth muscle cells. Number 1. Number 2, pacemaker cells. And autoexcitable cells, SA nodal cell, AV nodal cell, Purkinje cells, autoexcitable cells, people. Alright, these two kinds of cells exhibits depolarization by calcium and repolarization by potassium. Alright, so this completes our question. Now again, we have covered this question in our notes, people, in the topic nerve muscle physiology, subtopic action potentials. Let's take up question number 8. Which of the following acts by increasing phospholipase C? A very simple question, and one of a very important topic in endocrine physiology. Alright, now you have protein hormones, small proteins as well as large proteins, protein hormones, and protein hormones uses cell membrane receptors. Cell membrane receptors are of 3 types. Number 1, G protein coupled receptor. Number 2, tyrosine kinase receptor. Number 3, it's going to be cytokine receptors. Alright, number 1, G protein coupled receptor. Number 2, tyrosine kinase. Number 3, cytokine. Tyrosine kinase receptors are utilized by insulin, a single hormone belonging to this category. Tyrosine kinase receptor, this itself was a very important and very many times repeated question. The hormone that uses cytokine receptors is number 1, growth hormone, number 2, prolactin. So apart from growth hormone, prolactin and insulin, every other protein hormone as well as catecholamines uses G protein coupled receptor, which are of multiple subtypes. We have G protein that stimulates. We have an alpha subunit that is going to stimulate cyclic AMP. We have G protein, the alpha subunit that is going to inhibit cyclic AMP, and we have G protein that's not going to involve in cyclic AMP at all. All right. The first two mechanisms, GS as well as GI, they involve in cyclic adenosine monophosphate mechanism. While GS alpha increases cyclic adenosine monophosphate, while GI alpha decreases cyclic adenosine monophosphate level. While GIQ, to be clear, it's GQ. All right. So it's GQ mechanism, when GQ subunit is going to involve in activating phospholipase C, inositol triphosphate diacyl glycerol pathway. Phospholipase C, inositol triphosphate diacyl glycerol pathway, doctors. This is GQ pathways. Now cyclic AMP pathway will ultimately result in either increase or decrease in protein kinase A. So naturally GS alpha is going to increase protein kinase A, while GI alpha is going to decrease protein kinase A. So these are all the receptor families belonging to protein hormones, large proteins as well as small proteins. They use these kinds of receptors. Here, insulin and tyrosine kinase receptor is a very repeatedly asked question. At the same time, growth hormone prolactin using cytokine receptors with the second messengers like JAK and STAT, Janus kinase A, signal transduction activator of transcription. So JAK STAT pathway, growth hormone prolactin, cytokine receptors is one set of questions frequently asked. Insulin acts through tyrosine kinase receptor, other set of questions very frequently asked. And the third set of questions is on G protein coupled receptor people. For some unknown reason, for the past 3 years, we have lots of questions coming from G protein coupled receptor itself. All right. So let's get to the notes here, and again it's been completely covered in our notes, everything about G protein coupled receptors, the number of segments that spans a cell membrane, extracellular hormone binding domain, what is a G protein, what are the subunits of G protein, how does it splits, where does it go in resting state, what is getting attached to alpha subunit in an activated state, everything people, it's been completely covered. So for the sake of time, I'm just restricting to the questions that are in the discussion part, and I'm not getting into the depth of explanation. Guys, we have our notes for your better clarity and understanding. So guys, let's take up the next question. Two vessels, one with diameter D and length L, another with diameter 2D and length 2L, flow in second will be how many times of first, right? We have two vessels, first vessel with a normal diameter and a normal length, second vessel with a bigger diameter and a bigger length. So what's going to happen to the flow in the second vessel? That's the question. Now this question, guys, this is something so many times repeated in the past decade. Alright, when we were taking up our entrance exams, this is one of our very favorite questions in All India PG entrance exams as well as in DNB exams. It's been so long, after so much of time the question has got repeated. But it's a very easy question, very simple question. This is based on a law on hemodynamics called Poiseuille-Hagen's law, people. Poiseuille-Hagen's law, where the first part of the law states that resistance to a flow is related with a factor called 8 neta L divided by R to the power of 4. Alright, here Neta stands for viscosity. L stands for length of the vessel, length of blood vessel. And R stands for, this is not R to the power 4. I want you to remember it this way, alright. R to the power of 4 stands for, please understand, we are not dealing with rocket science here. This is not a mathematics, alright. The formula says it is the radius, but in practical terms, it indicates a cross-sectional area of a single vessel, alright. It is all about the cross-sectional area of a single vessel. What is the dimension of lumen of this one single vessel, people? So I can call this as cross-sectional area to the power of 4. We can even call this as radius to the power of 4. We can also call this as diameter to the power of 4. The law was described by a renowned physicist, so he used radius to describe the dynamics of water flow in a metal tube, rigid tube, right? So when it comes to biological limits, blood vessels are not rigid, you know that. So please do not think in terms of mathematics saying that radius is half of diameter. So if radius is increased, diameter is going to be twice. Don't get into that kind of risky adventures, okay? So please understand, we are here restricting ourselves to the luminal caliber, that is all. What happens to the luminal caliber, and if that changes, how does that influences flow? That is all we are going to restrict our discussion to, people. Now, you could able to understand with this picture, when viscosity, what do you mean by viscosity? Viscosity means stickiness, okay? Viscosity means stickiness, how sticky it is, right? The gummy nature. So viscosity means stickiness. When blood becomes very sticky, right, the flow becomes difficult and resistance increases. Please understand, viscosity is directly proportional to resistance. Number 2, as the length of blood vessel increases, resistance increases, people, remember this. So we experience a force called shear stress. The force is called as shear stress, and this shear stress is going to influence the blood vessel and blood flow, where the length of blood vessel, as it keeps increasing, the blood that is flowing underneath the blood vessel is going to get rub against this blood vessel, and this is going to cause a resistance. So more the length, more the resistance, my friends. And as the radius keeps increasing, as the diameter keeps increasing, you don't have resistance, right? Because there is enough space for the blood to flow. So diameter is inversely related to radius in 4th power. Please understand, if diameter changes by 1 time, the resistance, if diameter or radius increases by 1 time, the resistance drops by 4 times. That's very, very, very important. A small increase, 1 time increase in radius or diameter or caliber, luminal caliber, the resistance is going to fall by 4 times, because it is related to 4th power. Yes. And coming to the second half of the equation, right? Flow, the normal flow of a fluid, in this case blood. Normal flow of blood is going to be determined by pressure difference between 2 points. The pressure difference between point 1 and point 2, pressure 1 and pressure 2. And blood flow is inversely related to resistance. When the resistance is more, there is going to be less flow, alright? So this is the points you need to understand here. Now, as per the question, what do they say? In the second tube, you do have 2 times the diameter, which means 2 to the power of 4. 2 to the power of 4, this takes us to about 4 into 4, like that itself is 16, 16, and another 4 into 4, sorry, it's going to be 2 into 2, I'm sorry, 4 into, here people, 2 into 2 into 2 into 2. So it's going to be 4 into 4 people. 4 4s are 16. Alright, so with increase in diameter by one factor, if diameter increases by one factor, alright, yeah, we have 16 times increase in flow, and this gets us to 16 times drop in resistance. There is going to be a drop in resistance by 16 times and increase in flow by 16 times. Is that all? We also have a increase in length. We also have a increase in length. And you know very well, when the length increases, there is going to be an increase in resistance. When resistance increases, there is going to be a reduction in flow. So as the flow was increased by 16 times because of increased diameter, the flow was reduced by 2 times. Alright. So there is going to be a 16 time increase in flow, 2 times reduction in flow. Substitute this in the formula. Alright. We have resistance equal to 8 neta 2L now divided by pi 2 to the power of 4. Alright people, so this comes down to 2 by 16, that's 1 by 8, isn't it? Now the resistance has decreased to the point of 1 by 8. When the resistance drops to 1 by 8 times, the flow must increase by 8 times. The flow must increase by 8 times, as flow is equal to change in pressure by resistance. Alright. So this takes us to the answer people. The answer is option D, 8 times. It's a 2 time increase in diameter and 2 time increase in length. So at one point we are experiencing a drop in resistance, and the other side we are experiencing a accentuation of resistance. Together combined, we get a 8 time increase in flow with increase in diameter as well as increase in length. Alright. Now coming to the next question. Use of transcutaneous nerve stimulation to relieve pain is an example of conditioned pain modulation, central sensitization, gating of pain, descending inhibition. We have 4 different methods and 4 different options. And out of these 4 options, where does transcutaneous nerve stimulation fits? I think you would have had a practical experience with TENS doctors, with sports pain, with pain due to injury, fall and all. We tend to get physiotherapy where our physiotherapist treats us with TENS machine, isn't it? So what is actually TENS? We are going to repeatedly stimulate a nerve or a muscle so that there is going to be a momentary relief from the pain we are experiencing due to injury. Alright, let us get to see each and every heading first, and then we'll get to the answer. Let's start with conditioned pain modulation. Conditioned pain modulation is more of an experimental procedure. As of now, it doesn't have any greater therapeutic application people. It is still an experimental procedure. What is it? Now, a patient who is already suffering from a pain, suffering from a painful stimulus. Alright, now for this patient, we are going to introduce a second painful stimulus. Second painful stimulus at distant site. Second painful stimulus at a distant site. although not to the point of damaging the tissue. This is a nociceptive stimulus, no doubt about it, but this nociceptive stimulus is not to the point of tissue destruction or damage. Alright, with a patient who is already suffering from a painful condition, in a very distant site, if that same patient experiences another painful condition, there is going to be a temporary freeness from the initial painful condition people. In a very simple word, it's pain inhibiting pain. A painful stimulus at one site inhibits the perception of pain coming from a different site. Alright. So this kind of conditioned pain modulation is still in an experimental procedure. It has not reached any therapeutic application. Involves inflicting pain at a distant site, making the brain to be focused on the newer stimulus, forgetting the older stimulus or ignoring the older stimulus. Such kind of pain inhibiting another pain is called as conditioned pain modulation, and the second stimulus is called as conditioned painful stimulus. Conditioned noxious stimulus. So if a patient is repeatedly administered with conditioned noxious stimulus, there is a chance the patient will be ignoring and the patient will be consciously free from the pain of the original damaged site people. Such kind of method is called as conditioned pain modulation. Does this involve TENS? No. Why? Transcutaneous nerve stimulation, electrical nerve stimulation means a electrical stimulus, not a painful stimulus. TENS machine is going to trigger the neuron, is going to trigger the muscle. It is not going to cause a pain. So TENS is not a method of conditioned pain modulation. Alright. Then what is central sensitization? The neurons involved in nociceptive pathways. Nociceptive pathways as well as sensory cortex that senses pain as well as regions of thalamus. These neurons become hypersensitive to painful stimuluses. This doesn't involve the afferent neuron. This doesn't involve the receptor of pain. No. It is purely restricted to the sensory cortex and the regions of brain involved in pain perception, and they become very hypersensitive, which is why even though there is a low threshold stimulus, even though there is a low threshold nociceptive stimulus, this leads to pain perception. So hypersensitive central pain sensing structures leading to accentuated pain perception is called as central sensitization. Doctors, this has got nothing to do with transcutaneous electrical nerve stimulation TENS machine. So it is not a central sensitization mechanism. It is not a conditioned pain modulation mechanism. Now, number 3, gating of pain. What is gating of pain, people? Now, pain is carried by two pathways, two neurons. One is A delta neuron, number 2 C neurons. Both are very small fiber neurons. And these small fiber neurons carries the action potential through anterolateral spinothalamic tract all the way to sensory cortex. All the way to sensory cortex. Now, in the very same spinal cord, the same spinal dermatome or segment, doctors, will also have some large fiber neurons. Large fiber neurons in the order of A alpha, A beta. Now these large fiber neurons, A alpha or A beta, they get excited by conditions like touch, pressure, vibration and all, isn't it? But within the spinal cord there is a connection that we could able to see a interneuron, doctors, and this interneuron is involved in inhibiting small neurons. The interneuron in the spinal cord is involved in inhibiting small neurons. Large fibers are involved in exciting this interneuron. When large fibers develops action potential, through the inhibitory interneuron, small neurons are getting suppressed. So, if we excite a large motor neuron, naturally what happens? Because of activation in the large motor neuron and activation in the inhibitory interneuron, small fiber neurons are suppressed. Beautiful, right? This is exactly how acupuncture, massage, heat fomentation, they all work. Now, this mechanism of gating the pain transmitting neurons is called as gating of pain, also called as gate control theory, a very important entrance topic. In the previous decade, from 2010 to 2020, if you look at this year, the initial half, 2000 to 2010 to 2015, these years had lots of questions on this topic, gate control theory of pain, gating control of pain. So the few questions people, actually I'm surprised to see the paper, because these topics, Poiseuille-Hagen's law, where we just discussed, right, resistance and flow, gate control theory, these were all it's been the question of the past decade. But I'm surprised to see the questions are coming up in exam like INI-CET. It's something, it's something interesting. At the same time, it's going to make our preparation relatively easy, right? And all you need to do is to become very familiar and thorough in the previous year topics, people. That is all. So guys, this is gate control theory of pain. So by using TENS machine, transcutaneous electrical nerve stimulation, we are practically stimulating either the large fiber neuron, or we are going to practically stimulate a muscle, and through muscle stimulation we get again stimulation of large fiber neurons in the form of proprioception. So anything and everything through TENS is going to trigger the inhibitory interneuron, ultimately leading to inhibition of small neurons that carries pain sensations. Small neurons which are going to carry pain sensations. So A delta is going to carry superficial pain or fast pain, while C fibers are going to carry deep pain, people. So by applying TENS machine, we are not going to relieve the pathology. There is going to be a momentary relief for the patient from the pain, alright? That's gating of pain. And the last topic, descending inhibition, a very interesting topic to be understood. As the pain pathways travels from spinal cord, all the way to thalamus, from the thalamus to sensory cortex, there is going to be connections from the sensory cortex to regions in brainstem, out of which most important region is periaqueductal gray. Gray matter surrounding aqueduct of Sylvius that connects third ventricle and fourth ventricle. Number 2, rostral ventral medulla. When these two regions are getting excited by sensory cortex, there are going to be neurons starting from these two regions carrying information in the form of neurotransmitter to spinal cord, secreting chemicals like endorphins, enkephalins, as well as dynorphins. Endorphins, enkephalins and dynorphins, these peptides comes and inhibits pain transmitting neurons in spinal cord. They block pain transmitting neurons in spinal cord, doctors. Very interesting phenomena. This usually happens during wartime injuries. If you ever met a soldier or if you ever heard about these stories of wounded soldiers in battles, lots of Indian soldiers had this very motivational, inspirational stories where after even getting shot by bullets in their abdomen and limbs, they never reported to the army physician or army surgeon with severe pain. They just say, I got a wound. I just, fell into a pit or something. I got hit by a bullet or something. So they never lose their calm. They never lose their determination to fight. And they find it as a waste of time as they spend their time in the army infirmary. Alright people, how does this possible? Because of the cortical influence on the pain transmitting pathways. They actually don't feel the pain. Reason is so much of endorphins, dynorphins, enkephalins coming from the sensory cortex, limbic cortex and all that actually suppresses the pain, people. So descending pain inhibition is a natural physiological mechanism that is involved in suppressing the pain transmitting afferent pathways using certain chemicals like dynorphins, endorphins and enkephalins. So with these four logics, I think you could able to narrow down your answer now. Use of transcutaneous electrical nerve stimulation, TENS. Transcutaneous electrical nerve stimulation to relieve pain comes as an example of gating of pain, people. Comes as an example of gating of pain. Option C is the right answer for this question. Question number 10. Alright. Let's take up, this is a quick recall of whatever we just discussed. Conditioned pain, central sensitization, gating of pain and descending inhibition, people. Now it's just a nutshell of whatever we have just discussed. If you need, take a picture, that's all. So we have this covered in our notes, people, in the topic central nervous system, nerve fibers and pain pathways. Alright. Now 11th question, which of the following is not a part of innate immunity? Very interesting question. Which is not a part of innate immunity? Guys, let me be true to you. We just could able to narrow down to 3 options. We couldn't able to get the 4th option. So if you guys are willing to help us out, please do share your experience and the options. If you know extra anything else from your side, it will be very helpful for us as well as for our juniors. Alright, so guys, which is not a part of innate immunity? What is innate immunity? Innate immunity is something that you are already born with. Alright, you are not designed to attack any organism specifically. Alright, anything and everything foreign to you, you just go and kill, you just go and attack, right? So that kind of non-specific inborn immune mechanism is called as innate immunity. Now, if you're not very familiar with this word, I want you to understand innate immunity with a synonymous term called non-specific immunity. Non-specific immunity, people. All right, the cells don't have any specific targets, right? If the cell finds something foreign, that's it, it just go and kill. All right, people. So now what are the cells involved in non-specific, what are the cells that are not involved in innate immunity? That's the question. All right, so let's get to know T lymphocytes and B lymphocytes first. What are T and B lymphocytes, people? T lymphocytes and B lymphocytes belong to a category called humoral immunity, which is B cells and cell mediated immunity. T lymphocytes, both B as well as T lymphocytes belong to a common category called as acquired immunity. They are not innate, we call this as acquired immunity. What does this mean? When T cells and B cells are silent. When they are in the circulation, they don't react, they don't respond to any organisms straight away. In the presence of T lymphocytes and B lymphocytes, only when there is a specific organism seen, only when there is a specific organism seen in the vicinity of B lymphocyte, B lymphocyte is going to produce immunoglobulins specifically targeting against this particular organism. And these immunoglobulins are very organism specific. They go and kill that particular organism, people. T lymphocyte is one step even worse. T lymphocyte has got on the membrane major histocompatibility complex, which expects the antigen to be presented by another antigen presenting cells. Alright, let me take up another antigen presenting cells. Now this antigen presenting cell needs to present the antigen in the broken form. It doesn't need the full organism to get activated. Even if it is a broken form, that's okay. If the necessary antigens are presented to T lymphocyte by antigen presenting cell, T lymphocyte gets activated. So ultimately speaking, B lymphocytes and T lymphocytes belongs to acquired immunity. In another word, they belong to specific immunity. They belong to specific immunity pathway, and these two cells are organism specific. That's very important. Organism specific. That naturally takes us to the answer, option A. So which of the following is not a innate immunity? It's very obvious, option A, T and B lymphocytes. What is alpha defensin? What is leptin pathway? They are very interesting topics, guys. Alpha defensins are seen within Paneth cells of GIT. They are also seen within marrow cells, hematopoietic stem cells. Alright. They are also seen within myeloid cells. And these alpha defensins are involved in killing organisms, and they are not specific, unlike T cells and B cells. For example, unlike an immunoglobulin specifically designed against streptococcus, immunoglobulin specifically designed against staphylococcus, there is no organism specific defensin, doctors. It's a simple defensin which has got a same structure, same property against all the foreign organisms. It can be virus, it can be bacteria, it can be parasite, fungus, spirochetes, anything. The alpha defensin structure is just the same. So it's a non-specific material, non-specific chemical designed to attack any organism, unlike a immunoglobulin, unlike a chemokine, which are produced by B and T lymphocytes respectively, which are specific for each particular organism. That is alpha defensins. What is leptin, guys? Another important and interesting topic, leptin. You guys know very well, leptin is getting synthesized by adipocytes, right? It is getting synthesized by adipocytes, which is why leptin is also called as adipokine. The name itself indicates it has got a chemical structure similar to cytokines, like it is going to be very similar. It's going to be very similar to cytokines like interleukin 6, 11 and 12. So what does leptin do? Leptin practically activates, alright? Leptin practically activates neutrophils and other phagocytic cells, and it enhances, leptin enhances natural immunity or innate immunity. immunity. Alright people, so this question gets you a clear picture about the innate immunity as well as acquired immunity, guys. And remember, alpha defensin and leptin, they belong to innate immunity pathway. T and B lymphocytes belong to acquired immunity pathway. This picture, this chart, the table tells you the difference between innate immunity as well as adaptive immunity, specific immunity, people. Again, if you need, take a screenshot for your better understanding and revision. And we also have this in our notes very solidly explained, right? The different kinds of immune cells and different kinds of immune mechanisms involved in defense against organisms. All right, people. So that takes us to the 12th question. Wrong statement among the following about accommodation changes in high altitude ascent. All right. With high altitude, right? With high altitude ascent and accommodation, what is the wrong statement? What is not going to happen? That's one very important point. Please understand, you got to pick the wrong choice here. So again, guys, let me be true with you. I could able to get only 3 choices: metabolic acidosis, pulmonary vasoconstriction, and hypoxia. I don't know what's the 4th one. So if you are willing to, please help me out here, and let's get to the question. What happens with high altitude? We had a discussion about such a kind of logics and concepts in central cyanosis. Do you remember? With high altitude, the significant point is there is going to be a drop in atmospheric oxygen levels. There is going to be a drop in atmospheric oxygen level. When atmospheric oxygen level drops, naturally there is going to be a defective oxygen in lungs. You know this, the whole sequence, we just covered this. When lungs has got less oxygen, there is going to be less oxygen in arteries. And this is what is called as hypoxia. With hypoxia, people, you do have activation of peripheral chemoreceptors. The same story, right? When peripheral chemoreceptors are getting activated, we do have activation of respiratory centers. Respiratory center activation leads to hyperventilation. Now, nowhere in the body we are going to see this mechanism except in lungs. What is that? Very beautiful, very important mechanism. It's a defense mechanism, guys. When lungs gets affected by a disease process, and when there is a alveolar collapse, or when the alveolar content of oxygen is less, naturally the pulmonary vasculature supplying those alveoli gets collapsed. All right, why this is happening? When the damaged alveoli or less oxygenated alveoli is not receiving blood, that blood will be diverted to a neighboring alveoli which is functioning normally, so that oxygenation of blood remains unaffected. It keeps happening normally. So friends, to have an effective, normal, continuous oxygenation of blood, we expect a closure of pulmonary capillaries in region where the lungs are getting affected by any processes, ultimately leading to decreased oxygen in alveoli. So when there is hypoxia, this hypoxia, because of decreased oxygen in lungs as well. So here we are going to experience alveolar hypoxia. It's not tissue hypoxia going to cause this condition. This is alveolar hypoxia, which is going to lead to pulmonary vasoconstriction. So pulmonary vasoconstriction is very well happening because of hypoxia. So we do have hypoxia induced pulmonary vasoconstriction, there is an obvious hypoxia. So option B and option C will happen during high altitude. But my friends, because of hyperventilation, what's going to happen? Because of hyperventilation, as the patient breathes out very much, there is going to be carbon dioxide washout. And carbon dioxide washout will result in respiratory alkalosis. So the patient is going to manifest respiratory alkalosis but not metabolic acidosis. I repeat, the patient will develop respiratory alkalosis because of carbon dioxide washout. To compensate that, kidney will try to excrete more bicarbonate. So it is a compensatory mechanism made by kidney to lose more bicarbonate because the blood is already alkaline because of hyperventilation. This loss of bicarbonate will never ever get the pH back to acidic side, right? If you look at the patient's pH, it will be increased. It is still a respiratory alkalosis. Even though it is compensated, the primary problem is respiratory alkalosis and never ever metabolic acidosis, doctors. So there is a compensation but not a full-blown acidosis. So right answer for this question, right, which means the wrong statement among the following about accommodation changes is option A, metabolic acidosis. What's going to happen? We will be getting respiratory alkalosis, guys. All right. Now the whole thing is being explained in this chart. All right. Because of hypoxia, peripheral chemoreceptor activation, we have hyperventilation and respiratory alkalosis. And because of pulmonary vasoconstriction, there is going to be pulmonary hypertension. All right. And hypoxia is going to cause dilatation of blood vessels in the body. Everywhere hypoxia leads to vasodilatation, but only in lung there is going to be vasoconstriction. It's a beautiful process happening only in the lungs, people. All right. Never ever you could able to see hypoxia induced vasoconstriction except in lungs. All right. So because of pulmonary vasoconstriction, we get hypertension, and because of systemic vasodilatation, there is going to be more blood pressure. All right. When peripheral vessels dilates, of course, there is going to be a drop in diastolic blood pressure, but because the resistance is decreased, cardiac ejection is going to be more vigorous, systolic blood pressure increases. All right. So heart rate increases, cardiac output increases, myocardial contraction increases. As a result, systolic blood pressure increases, people, and that is the right answer for the question, guys. Okay, wrong statement about the following due to accommodations. All right, again we have covered this in our notes very clearly. It's in the topic respiratory physiology and the subtopic is high altitude, guys. Now 13th question, for a 4-year-old child who weighs 15 kg with serum creatinine 1 mg per deciliter, serum urea 100 mg per deciliter, what is the closest approximate GFR? That's the question. All right. Now you are not supposed to identify the exact GFR because you don't have the time for calculating GFR using formulas in your exam halls, right? So it's not an accurate answer, but you need to be very close. So how are we going to derive GFR? The best way to get GFR is by clearance method, but here we don't have any value relevant to clearance, creatinine clearance or inulin clearance, nothing. We have age, we have weight, all right, we have age, we have weight, and we have creatinine value. We have creatinine value and urea value. With age and weight, okay, what can be done to calculate GFR? We can use a formula called Cockcroft-Gault formula. Cockcroft-Gault formula can be used to calculate glomerular filtration rate, people, through which we can able to estimate eGFR, estimated glomerular filtration rate. And the formula goes like this: 140 minus age multiplied by lean body weight divided by serum creatinine into 72. So we have 140 minus age 4 and lean body weight is 15, serum creatinine is 1 and you have the value 72. Alright, let's keep it this way. We have, and if it is a girl child, and you got to multiply this with 0.85. Now, as I just told you, the question is beautifully designed. It's not exact value of GFR, it is the closest to possible range. So 140 minus 4 comes down to 136 multiplied by 15 divided by 72 on an average. Alright people, so we'll put it this way. When it comes to 136 and 72, let us try to take this into a normal value more or less. Let's try to keep this as 140 into 15 divided by 70 on an average, right? For a simpler calculation, so 70, 140, you get 2, 15 into 2, that comes to 30. Alright, in your question, you have 80, 50, 40, 33. The closest approximate value to GFR is going to be 33 people. You should thank your question setters if they get your question like this. Seriously, I'm saying, because how much time can be saved, how much tension can be avoided, right? You have literally just bypassed the mathematical difficulties in getting these EFR with smaller difficult numbers like 136, 72, 0.85 and all. How terrible. So guys, it's a beautifully designed question, alright? Closest approximate value to GFR is going to be 33, and that's the right answer, people. Alright, now even if you fix everything perfectly, 136 into 15 by 72, and if it is a girl child, it's 0.85, you'll get somewhat about 26. Still you will get 33 as the right answer because you don't have anything around 20 here. Alright, so that completes our 13th question. So please remember people, glomerular filtration in total, right, it begins by 6th week of fetal life. We have never got a question when it comes to pediatric GFR calculations, alright. So this is quite new and we have to ready for the future questions on this topic as well. So glomerular filtration begins by 6th week of fetal life. It continues to improve till 18 to 20 years because kidney will keep growing till 20 years. So as long as kidney is growing, you will have gradual increase in GFR. So in order to avoid this confusion, we got to narrow down GFR to approximating with body surface area. So GFR corrected to body surface area 1.73 square meter, right, corrected to body surface area will reach adult value even only by 3 years of age. Even after correcting to body surface area, adult GFR corrected to body surface area, pediatric GFR corrected to body surface area should come to equal values, right? Even though we correct with body surface area, the GFR reaches normal value like an adult value by 3 years of age. That's quite important. GFR in a pediatric population reaches adult value by 3 years of age. Alright. To be clear and precise, in pediatric population, Cockcroft-Gault formula should not be used. Alright, this is recommended by physiology textbooks as well as by Nelson. Please understand, pediatric textbooks do not encourage Cockcroft-Gault formula to be used for calculating GFR. So, you must also be familiar with another formula called the Schwartz formula, which is very commonly employed in calculating GFR in pediatric population, where you got to use a K value of 0.413 multiplied by the child's height in centimeters, height of the child in centimeters, and it must be divided by serum creatinine value. It must be divided by serum creatinine value, people. Now, this is a very gross oversimplification of Schwartz formula, but if you get exactly to Schwartz formula, you have different K values for different age groups. But I sincerely believe you won't get questions of that complexity in your INI-CET or NEET PG entrance exam, so you don't have to worry about the depth of those Schwartz formula, K value for every age group and all. Ignore it. Just be familiar with these two words. Schwartz formula has to be calculated using 0.4 into height divided by serum creatinine, and that is the formula you must use when it comes to pediatric population. Of late, the most advanced and most accurate method of calculating GFR in pediatric age group is cystatin C levels, right? Cystatin C is a peptide produced by nucleated cell, every single nucleated cell in the body. The advantage is it is freely filtered, but it is not secreted. Very important point. So creatinine, along with filtration in glomerular capillaries, it is also getting secreted by tubules, creatinine. So when creatinine production is very high in body, apart from filtration, there is also going to be tubular secretion that's going to give false values when we calculate GFR. Alright, so cystatin C, having the advantage of absolutely no secretions from the tubules, finds very superior to creatinine when it comes to GFR estimation. Alright, so it is absolutely not secreted. It is less affected by age, muscle mass and gender when compared with creatinine. So modern equations have started to include cystatin C also in evaluating or in estimating glomerular filtration rate, people, and my friends, that is the future. You can't just stick to Cockcroft-Gault formula or Schwartz formula alone for calculating GFR, because we are seeing top hospitals and statutory bodies like American Nephrological Societies and all, they have started using cystatin C measurements when it comes to GFR estimation. So it's not very far that we will start getting questions on cystatin C as well. You got to be very familiar and clear, and even to be precise, more knowledgeable on cystatin C when compared to creatinine. Alright guys, so that is the 13th question. And guys, we had a question on the topic of changes in body on second day of exercise. But let me be very truthful to you, I couldn't able to get the exact question and options. I'm sorry. Alright. But whatever with the limited data I could able to gather, this is all we had in the bits and pieces, right? So steadiness in a person doing exercise. But anyway, I'm going to give you what's going to happen. Alright people. So let me complete this topic, people. Cystatin C must be read in thorough detail, as well as the equations that include cystatin C also has to be studied, right? So guys, that completes our discussion of questions in the recent exam, the model questions in the recent exam, guys. I wish you all the very best for your upcoming NEET PG exams. May God be with you guys. Best wishes. Thank you very much.